Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Maths Maker Sessions. We will be running through a question with you guys to help you on a journey to a 250. We are currently in our neurology module, and this video is about auditory pathway. So here we have which of the following best describes the likely location of the pathology in this patient. A 40-year-old woman complains of hearing a constant ringing sound in her right ear, which has been persistent for the past 2 weeks. Audiometry reveals normal hearing thresholds, but a tuning fork test lateralizes to the right ear. Weber's test is also performed, with the patient reporting that the ringing sound becomes more pronounced in her right ear during the test. Which of the following best describes the likely location of the pathology in this patient? Cochlea, vestibulocochlear nerve, medial ear ossicles, superior olivary nucleus, or cochlear nucleus. So the patients complain of constant ringing sound in the right ear, normal hearing thresholds, lateralization of the tuning fork to the right ear, and exacerbation of the ringing sound in the right ear during Weber's test all suggest conductive hearing loss in the right ear. Now, in this context, the likely location of pathology involves the middle ear ossicles, specifically the stapes. So, the correct answer is C, middle ear ossicles. Talking about cochlea, the cochlear pathology will typically result in sensorineural hearing loss, and the patient's normal hearing thresholds make cochlear involvement less likely. Vestibulocochlear nerve pathology could lead to sensorineural hearing loss, but the tuning fork lateralization and exacerbation of symptoms during Weber's test suggest a conductive hearing loss, more indicative of middle ear involvement. Superior olivary nucleus, the lesions affecting the SON may result in auditory processing disorders, but are less likely to cause the specific conductive hearing loss described in this patient. Talking about the cochlear nucleus, the pathology at the cochlear nucleus level is less likely to present with the conductive hearing loss and tuning fork lateralization observed in this case. So this is your auditory pathway. So the sound first travels from cochlea towards the canal of 8, then towards the brainstem. Brainstem is travels through the cochlear nucleus, the superior olivary complex, the lateral lemniscus, the inferior colliculus, then the medial geniculate body. And at last, it reaches the brain in the auditory cortex, which is in the temporal lobe. So the sound here just goes through the ventricochlear nucleus towards the superior olivary nucleus, then the nucleus of lateral lemniscus, then the inferior colliculus, then the medial geniculate nucleus here, and then the auditory cortex or auditory part of the temporal bone. So this is the typical presentation of the auditory pathway. So it is not as high yield as the visual pathway, but what is high yield in this visual the auditory system are the hearing loss problems and the tuning fork test. So this is the basic schematic representation of the anatomy of the ear. So here you have your auricle or pinna, and then you have the external auditory canal, then you have the tympanic membrane, and this is the middle ear. So the obstruction anywhere between the external auditory canal and the middle ear will give rise to the conductive hearing loss. And then here you have the inner ear consisting of the vestibule, cochlea, semicircular canals. The pathology anywhere in this inner ear will cause sensorineural hearing loss. That is the one thing that I want to highlight in this image. So we have here the external ear, the middle ear, and the internal ear. Now, we have one more question here. So which of the following is the most likely cause of the patient's sensorineural hearing loss? A 65-year-old man presents with a gradual onset of hearing loss in both ears. On audiometry testing, there is bilateral symmetric sensorineural hearing loss with higher frequencies more affected than lower frequencies. The patient denies any history of recent noise exposure, ear infections, or use of ototoxic medications. Inspection of the external ear and tympanic membranes reveals no abnormalities. Now, which of the following is the most likely cause of the patient's sensorineural hearing loss? Cerebral impaction, acoustic neuroma, chronic otitis media, presbycusis, or sensory neural hearing loss, sudden sensory neural hearing loss. So the patient's presentation with bilateral symmetric sensorineural hearing loss, gradually onset and more pronounced in higher frequencies is consistent with presbycusis, which is also called as age-related hearing loss. Now, presbycusis is a common cause of sensorineural hearing loss in the elderly and typically affects the higher frequencies first. The cerumen impaction can cause conductive hearing loss. Remember, I told you that whenever there is obstruction anywhere in the external ear or the middle ear, it can cause conductive hearing loss. But it typically does not result in bilateral symmetrical sensorineural hearing loss. Acoustic neuroma can cause sensorineural hearing loss, but they often present with unilateral symptoms and the gradual onset is less characteristic. Chronic otitis media can lead to conductive hearing loss, but sensorineural hearing loss is not a typical feature. Sudden sensory neural hearing loss presents a rapid onset sensory neural hearing loss in 1 year, often occurring over hours to days. The gradual onset and bilateral nature in this patient make sudden sensory neural hearing loss less likely. Now let's talk about different tuning fork tests. Now, the tuning fork test is where you compare the air conduction and the bone conduction in the same ear. So positive Rayleigh means that normal, positive Rayleigh means normal. So normal is what? So normal is air conduction is more than bone conduction. So there are two ways by which you can do Rayleigh test. The number one way is when you place the tuning fork in the mastoid, okay, master process, and then you ask the patient to raise the hand whenever he or she stops hearing the sound. Now, whenever the patient says that I have stopped hearing sound, or when the patient raises the hand, then you again bring the tuning fork towards the lateral ear, and then if the patient still perceives it, if the patient still perceives the sound, then air conduction is more than one bone conduction, and this is called as positive Rayleigh. Okay, that is normal. But if the patient cannot hear in the air conduction, okay, if the patient cannot hear in this air conduction, then it means that there is some pathology in between the external ear or middle ear. Because what happens here in the bone conduction part is that the sound is transmitted through the bone, escaping the external ear and middle ear towards the inner ear directly. And whenever there is pathology in this external ear and middle ear, then the ear conduction or the conductive hearing loss is there, and the air conduction is decreased. Now, whenever there is bone conduction more than air conduction, that is called as negative Rayleigh test. Okay, negative Rayleigh test, which is called as the conductive hearing loss. Now, the second way to do the Rayleigh test is that you just hold the tuning fork on the bone conduction part here, and just after some time, you just again hold the tuning fork here and ask the patient which one is louder. So if the air conduction is louder, if this part is louder, then air conduction becomes more than bone conduction, and it is called as positive Rayleigh or normal hearing. Now, talking about the Weber test. A Weber test is when you just put the tuning fork on the medial of the medial side of the forehead. Then the sound is transferred towards by the bone conduction towards the inner ear, right? Towards the inner ear. Now, whenever there is sensory neural hearing loss, then the sound is perceived more on the normal side, right? The sound is perceived more on the normal side, and this is called as the lateralization of the sound, right? There is no inner ear, there is pathology in the inner ear. So even the sound travels up to the inner ear or even the outer ear is intact. Since the main pathology is here, there will be decreased sound perceivance in the affected site. So now whenever the waiver, if there is sensory neural hearing loss only, the waiver will be lateralized to the normal ear. But when there is conductive hearing loss, then the external sound is masked. So all of the sound that is going through the bone conduction reaches the inner ear than the normal side. In normal side, since the external ear and the middle ear is intact, there is masking of the sound by the tuning fork because of the sound from the external surroundings. So that's why in case of conductive hearing loss, the waiver is lateralized to the affected ear. Now, summarizing all of this, so some of the common causes of hearing loss are noise-induced hearing loss, like damage to stereociliated cells in the organ of Corti, loss of higher frequency hearing first, and certain extremely loud noises can produce hearing loss due to tympanic membrane rupture. Presbycusis is the aging-related progressive bilateral symmetrical sensorineural hearing loss, often of higher frequencies due to the destruction of hair cells at the cochlear base. Now, again, this is all I have told you about the Weber test. This is the normal, this is the conductive hearing loss, that is the localizes to the affected ear in case of conductive hearing loss because of the decreased transmission of the background noise, the environmental noise. The sensory, in case of sensorineural hearing loss, it localizes to the unaffected ear or the normal ear. Now this is our Rayleigh test, okay? Air conduction more than bone conduction. This is the bone conduction more than air conduction in case of conductive hearing loss. And again, the air conduction becomes more than bone conduction in case of sensorineural hearing loss. Thank you for watching. Keep studying hard.